Recording in progress.
We have a big heart.
At the Karen Hospital, our big heart acknowledges everyone is special. So from the day we deliver you into the world, you come first. Our leadership in heart diseases has put us at the heart of healthcare. State-of-the-art technology, endearing, compassionate care, and the determination to strengthen healthcare systems with quality training facilities. Our big heart beats for all. We partner with medical professionals to ensure affordable, universal healthcare closer to the people and across our borders.
We have a big heart.
The Karen Hospital, a heart for healthcare.
My name is Dr. Carlo Okorie. I'm the consultant cardiologist. I'm the head of cardiology department, Cedarcrest Hospital. I also head the cardiac catheterization lab. In the cath lab, like the one we have in Cedarcrest Hospital, we're able to look at the blood vessels supplying the heart. So in terms of diagnosis, we're able to identify areas in the blood vessel that are blocked. That way, we can as well also go ahead to do some interventions like opening up these areas. Traditionally, what we've had in Nigeria has been places where you have open heart surgeries, okay, which is an extensive procedure where you open up the heart. But actually, the cath lab helps you to repair certain valves in the heart without necessarily doing an open heart surgery. And we have interventional cardiologists on ground who does this procedure. We're also able to put what we call pacemakers. Now, for patients who also have heart failure, especially advanced heart failure, we can also put what we call ICDs, that's defibrillators. These ICDs helps to prevent sudden cardiac death in patients who have advanced heart failure. We're also able to work on the blood vessels that supply the kidneys. Certain people have what we call renal artery stenosis. What this means actually is narrowing of the blood vessels that supply the kidney. Through the catheters, we can make diagnosis of areas of the blood vessels that are actually blocked, and we can go ahead to open up these blocked blood vessels, thereby saving the limbs and also saving the brain. In certain situations of stroke. If the patient presents early in the cath lab, we can do some interventions and open up areas of blood vessel supply in the brain. These are things that we've been able to achieve and we are doing currently in Cedarcrest Hospital, Abuja. People do not need to travel outside the country to have these procedures done. We have interventionists, that we have experts that are able to get these procedures done here in Cedarcrest Hospital, Abuja. This procedure usually lasts within 30 minutes to an hour. It's life-saving, it's innovative. You don't need to go outside of the country to have these procedures done. We are doing this right here in Cedarcrest Hospital in Abuja.
Are you hypertensive, diabetic, suffer from chest pain, have difficulty breathing, swelling of the legs, or any other heart conditions? Cedarcrest Hospitals Abuja, in conjunction with the Caribbean Hospital Nairobi, Kenya, are proud to present to you a 3-day free cardiac camp. There will be free heart consultations and screening, coronary angiography, cardiac intervention and treatment in our ultra-modern and state-of-the-art cardiac catheterization lab, where heart procedures can be done without open heart surgery. The venue of the camp is at Cedarcrest Hospitals, located at number 2, Sambakwe Street, Gudu District, Apo, Abuja. Date, Monday, 29th November to 1st December 2021. Time, 9 a.m. to 4 p.m. daily. To register, call or text your name and location to 090-880-40880. See you there.
So, good morning, everybody. My name is Dr. Johnny Kennedy, and I'm your moderator for today's webinar session. Our webinar session for today is brought courtesy of Cedarcrest Hospitals Limited, Abuja, in conjunction with the current hospital, Nairobi, Kenya. And this is part of our community social responsibility initiative in keeping with our objectives of providing quality healthcare to individuals internationally and even locally. Today, we'll be having a webinar session themed Prevention of Sudden Cardiac Death, possibly enhanced cardiac catheterization interventions. And we shall be having 3 speakers or 3 presenters. And I would just like to give us a format of how the whole session will go. So we shall have all 3 presenters give us their presentation. Then at the end of all the 3 presentations, we shall have a session for question and answers. However, we would like to inform you that while the presentations are going on, we should type in our questions into the chat box. And then at the end of all presentations, we are going to read out those questions, and then they'll be answered by each presenter as it concerns them. Please, let's ensure we do that, and to take all your questions and within the ambit, the limited time we have. Also, this is a reminder that as regards CME points for those attendee doctors, we are going to scan and email the CME points based on those who registered and attended this particular webinar session. I say also that this webinar session is a prelude to the cardiac camp that will be coming up on the 29th to 1st of November. That's 29th of November to 1st of December from 9 a.m. to about 4 p.m. So let's take note of that we'll have the cardiac camp between 29th of November and 1st of December from the hours of 9 a.m. to 4 p.m. And it's worthy to note that we should invite our friends and our relatives, as consultations will be free and there'll be discounts on procedures and treatments. I will invite at this point in time one of the presenters to come up with his presentation, and that is Dr. Kalu Okore. Dr. Kalu Okore is a consultant cardiologist and head of cardiology department of Cedarcrest Hospitals, Abuja, where he oversees the non-invasive and cardiac catheterization unit of the department. He's a graduate of the University of Calabar Medical School and a fellow of the West African College of Physicians. And he has expertise in non-invasive cardiac interventions and preventive cardiology. He has worked with several cardiovascular surgeons in successful cardiac procedures. I will now welcome Dr. Kalu Okore for his first presentation. So while we're waiting for Dr. Kalu, I just want us to have the promotional. Dr. Kalu.
Thank you for the introduction, Dr. Johnny. Is it possible you can give a brief on what to expect from this presentation, or is it possible to allow the other presenters come in if your first presenter is not available at this time?
Okay. Thank you, my MD, Dr. Melo. So while we wait for Dr. Kalu, I think I'll go ahead to introduce the next presenter, that is Dr. Anthony Gikonyo. Dr. Anthony Gikonyo is the Director and Interventional Cardiologist at the Karen Hospital, Nairobi, Kenya. He is an interventional and non-invasive adult cardiologist with over 18 years experience. He has performed surgical and interventional coronary artery and aortic procedures and actively participated in continuous medical education at the Karen Hospital. He's a graduate of the Howard Medical School and a member of the Royal College of Physicians in the United Kingdom. Dr. Anthony Gikonyo is part of the heart team, which performs regular coronary and artery bypass graft at the Karen Hospital, Nairobi, Kenya. He has also published works on coronary artery bypass graft surgery, and I would like to welcome him for his presentation at this moment.
Thank you very much for that presentation. We're just loading up the presentation to share on the screen. Good. So I think that we can all see and hear me as well. My name is Dr. Anthony Gikonyo from the Karen Hospital. Thank you very much for inviting me to join in this cardiac CME, and also as a preamble to the cardiac camp that we'll be carrying out at Cedarcrest in Abuja next week. My presentation is on sudden cardiac death. We'll be discussing part of the background to sudden cardiac death, and then what interventions can be done in the cath lab regarding treatment of people who have survived sudden cardiac death or who are at risk of sudden cardiac death. So as we know that sudden cardiac death is any cause of death, usually within 1 hour of presentation or onset of symptoms, and is very rapid, and in the majority of patients it's a sudden event. It's not something that most people can anticipate, and because of how quickly it progresses from symptoms to actual death, we don't have much time to intervene to save somebody's life. And so what is important is, one, knowing, I guess, who's at risk, and if we're at risk, how increase that risk. You can see that the majority of people who will suffer sudden cardiac death will be people who have never had any medical problem or never had any clinical event, and those would cover up over 50% of the patients. Then you have the other groups who either have known a disease such as high blood pressure or diabetes, or who have had diseases of the blood vessels, which are acute coronary syndromes. And then finally, there'll be patients who have had an abnormal heart rhythm that causes the heart to beat in a way that doesn't allow blood to flow to the whole body, and therefore leads to death. Approximately 50% of cardiac arrests occur in individuals without a known heart disease. However, when postmortems are done on these patients, on these people, from what's concealed ischemic heart disease, meaning that there is a narrowing or blockage of a blood vessel to the heart that was previously undetected, and the patient did not have any symptoms such as chest pain or difficulty breathing when they were walking or climbing stairs. And this is the first episode known, or that this is the first presentation of the symptoms, and then leading to sudden cardiac death. You can see here that this is a slide that just tries to help explain, whereas the general population will have the most events of sudden cardiac death, their actual incidence, or the actual the absolute number may be high, but when in general, whereas in patients, for example, who have had heart failure, that meaning that when their heart pumps, it's not pumping more than 30%, the normal is 50%. The actual number of patients having events would be small, but the incidence, meaning within that group, the number of people who may have sudden cardiac death is high. I know there'll be questions at the end, and we've agreed that I guess people will write questions, and if there are any questions related to this slide, I'll be happy to go further into it during the question and answer session. In the young, the likelihood, the cause of sudden cardiac death is usually inherited. Either they have abnormal heart rhythms, or their hearts are big and not functioning well, or they may have an infection that affects the heart and leads to sudden cardiac death, or there's a possibility of substance abuse. In older populations, it's more likely that they have blocked blood vessels, coronary artery disease, or they may have valvular heart disease, which means that their valve is not opening or closing well, leading to sudden cardiac death, or they may have HF, which is heart failure. The approach to prevent sudden cardiac death in the general population relies on trying to find out which patients are more likely to have a risk of sudden cardiac death, and in particular,
He's muted. Has muted himself.
Thank you. I apologize for that. So going back to this slide, we're saying that to prevent sudden cardiac death in the general population, the easiest way is to identify patients who are at risk of developing ischemic heart disease, meaning that these are patients or people who are likely to have narrowing or blockage of the blood vessels to their heart. And this can be done in the office by performing a risk score analysis where we look at a patient's age, gender, blood pressure, weight, risk factors such as whether they have high blood pressure or diabetes, and then putting all these together to determine whether they are high, moderate, or low risk as far as the likelihood of sudden cardiac death. And then once we do that, then we can address those risk factors that we can control, such as blood sugar, cholesterol, blood pressure, smoking, cessation, and controlling somebody's weight so that they fall into the what we call the normal body mass index, which also will decrease the risk of sudden cardiac death. Sorry, I'm just having a technical issue here as far as getting to the next slide. Oh, there, no, it's worked, sorry. So this is from our national guidelines in Kenya, and I'm sure they're applicable to all countries. And the reason why I've highlighted this slide is just to indicate that this risk assessment is not just for cardiologists or physicians, it's for anybody in the medical, any medical healthcare worker. And because we can provide health education about how to control blood sugar, how to control blood pressure, how to stop smoking. And usually the best time to do this is when somebody comes into contact at the very basic level of healthcare, and rather than waiting until they're being seen by a specialist physician or a cardiologist. This is another slide just highlighting the modifiable risk factors, which we've discussed, and then the non-modifiable risk factors. Of course, in our setting, rheumatic heart disease is an important risk factor, and also HIV. When now we talk about procedures that we can do in the cath lab, we're going to concentrate on coronary angiography, which is a test that allows us to see a person's blood vessels and determine whether they're narrowed or blocked. This can help us identify patients who have this problem early and then treat them if required. And this is usually applied had risk factors or who during the office visits, we may do what we call a stress test, and if that is positive, then they end up in the cardiac catheterization laboratory, or if they're survivors of sudden cardiac death, in particular with patients who've had ventricular arrhythmias, which is an abnormal heart rhythm. This is a slide from the European Society of Cardiology, just indicating. This is a slide from the European Heart Association, just indicating that patients who've had chest pain should be referred for a coronary angiogram to ensure that they do not have any blocked blood vessels. Sorry, I'm told I was being a bit soft, so I'm trying to speak up so that I can be heard better. This is another slide from the same ESC that suggests that in patients who then have been determined to have blocked blood vessels should definitely undergo what we call reperfusion therapy, which is unblocking of the blood vessels. And I'll show one or two examples of that. Whenever somebody has chest pain, ideally they should have an ECG done, which is what I'm showing on this slide. And that ECG can be interpreted by the physician, cardiologist, even medical students now, because we're training them to do that, to determine whether this is the ECG shows any blockage of a blood vessel. In this case, and it might not be that easy to appreciate, this level is the baseline where my cursor is, and you can see this line is above the baseline, and it's more prominent in this lead, which is V2 or V3, and this indicates that there's a blocked blood vessel to the heart. It was taken to the cath lab. You can see where the arrow is pointing. That's where this area is where the blood vessel was blocked, and after we placed a stent, which is a wire coil into this blood vessel, you can see that there's nothing going forward down this, where my cursor is following. But in the next picture, you can see that now there's a blood vessel that's quite clear that wasn't there, that wasn't there before. And of course, there are two blood vessels overlapping each other, but you can see here there's no blood vessel coming straight down, whereas here you can see it. And this is a procedure that we routinely do in the cath lab for patients who have a blocked blood vessel and who are at higher risk of sudden cardiac death. And if we are able to open the blood vessels, then this decreases their chance or eliminates the chance of sudden cardiac death. This is another ECG. I know that there are lots of our participants who are not medical. I'll try and keep it as simple as possible. Again, we'll looking at the cursor, you can see that this line is above the baseline. This is indicating that this is a blood vessel to the right side of the heart that's blocked. And when we went to the cath lab, we can see that this is the tube that we insert into the body. This is the medicine or the dye that we inject to show us the blood vessel. And this blood vessel ideally should continue all the way down and turn around to form a C shape. But in this case, you can see there's a complete cutoff there, and that was fixed later. Sorry, I don't have the follow-up slide for this, but I have something similar coming up. This is what we is an example of ventricular tachycardia. And this is a patient who came with an abnormal heart rhythm. And when we shocked them, this is what and then because we could still see that there was this level is above the baseline, they went to the cardiac catheterization laboratory, and we opened up we found that one of the blood vessels was blocked, and we opened it successfully, and the patient went home safely. I'm hoping that this should play, and it should play. Just going to mute it because we don't need the volume. Let's see. So this is an example of a blood vessel that was blocked, and you can see here there's no flow beyond this point. And in the next slide, this is what the final picture looks like, where if you remember the first slide, there was no flow from here. You can see that there's a stent that covers from here down to here, and this whole blood vessel now has blood flowing. This is a patient who also had a heart block, and that's what this wire indicates here. We had placed it so that we could make sure that the heart rate remains at 60 because it had gone down to 30 during the procedure, to make sure that we could successfully complete the procedure. This is a slide just has many parts to it, but the message here is just explaining that in patients who have chest pain and therefore are likely to have coronary artery disease or blocked blood vessel and therefore are likely to be at high risk for sudden cardiac death, these are the timelines to determine blood vessel. You should do a blood test within an hour. If the blood test suggests that the patient is having a heart attack, into hospital as quickly as possible. And once they get to hospital, then they should be taken to the cath lab for an angiogram, which is what I have illustrated earlier. And if they require treatment, that should be done as quickly as possible. Finally, even though we've been talking a lot about cath labs, the main thing to remember is that prevention is always better than a cure. And these are the recent guidelines, again, from the European Society of Cardiology, highlighting that looking at population, the general population, finding ways to determine their risk for cardiovascular disease, finding ways to have discussions and giving personalized treatment decisions to decrease those risks will eventually lead to a decrease in sudden cardiac death and fewer people requiring the services of a cardiologist in the cath lab. Thank you very much.
Thank you very much, Dr. Anthony, for the concise presentation. And I believe we all followed through. At this point, I would like to bring on the next presenter in person of Dr. Kalu Okori, who, like I earlier said, is a consultant cardiologist. That is a consultant cardiologist and head of cardiology department of Cedarcrest Hospital, Abuja, where he oversees the non-invasive and cardiac catheterization unit of the department. And he is a fellow of the West African College of Physicians and has expertise in non-invasive cardiac intervention, preventive cardiology. He worked with several surgeons in successful cardiac procedures. So I will call on Dr. Kalu Okori now to give us his presentation. Please remember, let's be sending in our questions via the chat box. And at the end of all three presentations, we shall take in the questions and answer them. Thank you as we continue.
Thank you, everyone. So I'm to take the general overview of sudden cardiac death, and I'm going to walk you guys through the risk factors, the epidemiology, the indications, and some of the procedures used in prevention of sudden cardiac death that can be done in the cardiac catheterization laboratory. So sudden cardiac death is an unexpected cardiac death that occurs within 1 hour of symptom onset. So you have a patient who presents with chest pain, within 1 hour he dies, or a patient who presents with palpitations, awareness of heartbeat, within 1 hour he dies, or a patient who presents with difficulty with breathing, within 1 hour patient dies. Patient could have had background heart disease or unknown background heart disease. So that defines sudden cardiac death. So trying to use the symptoms to define this usually is not really specific. Symptoms can just be suggestive. It's important to know that patients who experience sudden cardiac death with the first presentation of patients who die out of hospital cardiac arrest. Epidemiology: over 7 million lives get lost in a year from sudden cardiac death. Over 300,000 people die in the United States from sudden. It's important of individuals who die from sudden cardiac death actually have coronary artery disease, and you wonder why it is so. So patients who have coronary artery disease usually have scars in the heart, and those scars predisposes them to having arrhythmias. These are abnormal heart rhythms, which could be fast, usually from the ventricles, what we call tachyarrhythmias, ventricular tachycardia, or ventricular fibrillation. It's important to know that sudden cardiac accounts for over 20% of mortalities in the Western world. In developing countries, it's found that sudden cardiac death parallels the rates of coronary artery disease. Remember what I said before, that sudden cardiac death usually comes from coronary artery disease. A study in Nigeria in Medical Teaching Hospital, it tries to look at the prevalence of causes of sudden cardiac death. So dilated cardiomyopathy accounted for 18% of patients who died suddenly. Ischemic heart disease topped the chart, 39%. Peripartum cardiomyopathy, that's people who developed heart failure during pregnancy or immediately after pregnancy, that accounted for 22% of causes of sudden cardiac death in Nigeria. Pulmonary hypertension, these are people who had elevated pulmonary artery pressure, accounted for 4%, and rheumatic heart disease accounted for like 17%.
See as T3 possibility of T3 toxicosis.
Mechanism of sudden cardiac death. Okay, what typically happens is that you have an anatomic substrate. Okay, what we mean by this is that you've had an insult, an injury to the heart, which could be from myocardial infarction. So that predisposes the heart to developing electrical instability. This can lead to ventricular tachycardia, what we call malignant ventricular arrhythmias. These are arrhythmias, fast ventricular heart rate that leads the patient to losing his life suddenly if not addressed. Causes of sudden cardiac death. On your left of the screen, you could see factors relating to coronary artery disease. Remember, coronary artery disease, like I said before, is the major cause of sudden cardiac death all over the world. So if you're smoking, if you have this lipidemia, if you've got hypertension, if you've got diabetics, you've got obesity, you're obese, you have a sedentary lifestyle, these are all risk factors that predispose the patient to having coronary artery disease, which is the major cause of sudden cardiac death in our population and all over the world. Then you also have specific factors related to cardiovascular disease, topping the chart, like I've said before. Then cardiomyopathies. These are heart muscle diseases. Peripartum cardiomyopathy, heart muscle disease that's developed during the period of pregnancy or around pregnancy. Hypertrophic cardiomyopathy. These are people who have unexplained thickened walls of the heart, especially in young athletes. Okay, dilated cardiomyopathy, people who have dilated heart muscles. Okay, then myocarditis. These are inflammatory disease of the heart, could predispose the patient to having sudden cardiac death. Okay. Then congenital heart disease. These are heart diseases that develop from birth. Valvular heart disease, infiltrative cardiac disease, commercial cardiacs. People who have non-traumatic trauma to the heart, and that could lead that could cause.
Sorry to interrupt, Dr. Kalu. Can you scroll your slides, please? Scroll your slides. Thank you.
I'm scrolling it.
Oh, okay. It's not coming out in the presentation. I guess it's the same perfectly. No, your slide is stuck on the introduction.
Wow.
You might stop sharing and start sharing again, and then you scroll it through there.
So while we're waiting for Dr. Kalu to share his screen, let's be reminded that we're expecting questions. So let's send our questions through the chat box so that they can be addressed at the end of all three presentations. Thank you. Okay, Dr. Kalu, I think you can start talking. I think we're seeing the slides moving now. So you can continue.
Okay, I was trying to talk about the epidemiology of sudden cardiac death in Nigeria. Okay, looking at the chart there, you could see that ischemic heart disease tops the chart. 39% of patients who died suddenly from cardiac causes from ischemic heart disease. Dilated cardiomyopathy was 18%, peripartum cardiomyopathy 22%, pulmonary hypertension 4%, rheumatic heart disease topped the chart with 17%. This was a study done in Vessel Medical Teaching Hospital. It was a 2-year retrospective study involving 388 patients. Okay, and almost 80% of them had heart failure. Mechanism of sudden cardiac death. So what you have is you've had an injury to the heart, which forms an anatomic substrate. When you have that, then you have electrical instability, okay? Ventricular tachyarrhythmias. Predominantly ventricular tachycardia, ventricular fibrillation is actually responsible for most of the causes of sudden cardiac death in these patients. It's important to know that left ventricular dysfunction is the major factor that is chance to sudden cardiac death. So you've got patients having chronic coronary thrombosis, stenosis from coronary artery disease. This leads to ischemia, could lead to electrical instability from the scars that causes electrical instability and predisposes the patient to developing sudden malignant ventricular arrhythmias and could predispose the patient to having episodes. So the causes, on your left, you could see most of the causes you see there are actually risk factors for coronary artery disease, family history of premature coronary artery disease. Some families have unexplained reasons for having early onset coronary artery disease. People who smoke, dyslipidemia, hypertension, diabetes, obesity, sedentary lifestyle. Specific factors related to cardiovascular disease like coronary artery disease, still topping the chart, is a major risk factor for sudden cardiac death. Then you have cardiomyopathies, myocarditis, congenital heart disease. These are people born with heart defects. Valvular heart disease, in this part of the world, you have rheumatic heart disease, topping the least causes of valvular heart disease. Infiltrative cardiac diseases, commotion carditis, aortic dissection, and pulmonary embolism. Still talking about the risk factors for sudden cardiac death. Older age, the older you are, the more at risk you are developing sudden cardiac death, because the older you are, the higher the risk of developing coronary artery disease. So the key factor here is coronary artery disease is something that is majorly responsible for developing this, what we are talking about today. Cigarette smoking is known that 2.5 is that people who smoke more than 20 cigarettes in a day from the Framingham study have higher risk of developing sudden cardiac death. Males are more likely to have sudden cardiac, 75% of the goal. And this what we are discussing today has a bimodal presentation. People 0 to 6 months, sudden infant death, and people above 45 years also. Hypertension, diabetes, hypercholesterolemia, obesity, family history of coronary heart disease, left ventricular dysfunction. So echocardiography remains key. It remains a key factor in evaluating cardiac patients because it helps you to risk stratify this patient. Patients who have left ventricular ejection fraction less than 35% are at risk of developing sudden cardiac death. Because at that ejection fraction, you're predisposed to having malignant ventricular arrhythmias that could lead you to die suddenly. So SCEF trials supports this idea. So in history of heart failure, left ventricular hypertrophy, poor functional status, people who do not exercise, people who have baseline tachycardias, heart rate that are more than 90 beats per minute. They are higher. If you have a faster heart rate, you're more predisposed to having sudden cardiac deaths. People who have baseline abnormal electrocardiograms, AV bloods, QT dispersions, non-sustained ventricular tachycardia, T-wave alternance, and in this also sustained ventricular tachycardia, long QT syndromes. People who have abnormal autonomic markers are also at risk of developing sudden cardiac death. So prevention, when we talk about prevention in any disease, we talk about primary prevention and secondary prevention. So primary prevention, you're looking at screening the general population, because cardiac diseases usually sometimes do not present with symptoms. So the first presentation could actually be studying cardiac deaths with thyroid on that electric field and all that. So you need to screen the general population, risk profiling. Are you diabetic, hypertensive, people who have heart diseases, people who have heart failure? So you need to risk profile the patients. Pharmacological therapy. So if the patient has got ischemic heart disease, you want to put this patient on beta blocker, because beta blockers, they are known to suppress ventricular tachycardia and ventricular fibrillation. You want to put them in ACE inhibitors because this has been shown to improve mortality. Patients also with coronary arteries are advised to follow lifestyle modification, dietary modifications, and all that. ICD implantation is a form of primary prevention, especially in patients who have heart failure with reduced ejection fractions. You want to put them on ICDs because they are at risk of developing sudden cardiac death. And secondary prevention, these are people who have survived cardiac arrest before. To do cardiac interventions for these patients, which is the emphasis of this presentation. So what's the role of cardiac intervention in preventing sudden cardiac death? Cardiac interventions include procedures like angioplasty, stenting, cardiac ablation, cardiac surgeries, and embolectomies. Angioplasty primarily talks about, you want to look at the blood vessels, areas of obstruction, you want to open them up so that the heart gets revascularized. So the charts you're seeing here shows you a narrowed blood vessel. The first stuff you're seeing there is there's a narrowing from cholesterol plaque. Number 2 shows you when you're now putting your balloon. Number 3, you inflate your balloon. Number 4, you remove your balloon and the vessel is revascularized. The patient is good to go. Cardiovascular defibrillator therapy. ICDs do usually to identify fibrillations or abnormal heart rhythms and correct them. Studies have shown that ICDs are superior to use of anti-arrhythmic therapies. So the AVI trial, the CIDS trial, and the CASH trials are actually evidence to support the use of ICDs in prevention of ventricular arrhythmias. So what are the indications for ICD implantation? These are includes post-myocardial infarction patients. So if a patient has suffered a heart attack, just like the layman will look at it, and has ejection fraction less than 35%, many trials shows us that 80%, there's the 80% reduction in sudden cardiac death risk and 50% reduction in total mortality in this kind of patients. Patients who have heart failure on optimal medical therapy, New York catheterization stage 3, 4, and who have broad QRS complex, which shows you that the patient has some form of left bundle branch block or intraventricular conduction defect with ejection fraction less than 35%. These are the patients that you can see today. The next day, the patient is brought into the emergency death. So these patients will benefit from ICDs. Patients who have syncope of undetermined origin, patients who have invisible ventricular tachycardias or ventricular fibrillation electrophysiology. So you do electrophysiology studies and you induce arrhythmias and the patient develops a ventricular tachycardia that is not corrected by the use of anti-arrhythmic drugs. These patients will benefit from ICD implantation. Patients who have significant left ventricular dysfunction, like I've mentioned before, non-ischemic cardiomyopathy. These are patients who develop dilated cardiomyopathy that is not from coronary artery disease. If they have reduced ejection fraction, they will benefit from ICD implantation. Hypertrophic cardiomyopathy. These are patients who developed asymmetric muscle hypertrophy, sudden cardiac death in heart legs. So if you have a patient who has thickened heart muscles with left heart flow tract obstruction, these patients are at risk of developing sudden cardiac death. So there are risk stratification and indications for implantation of ICD in this patient. If the patient has suffered ventricular tachycardias, ventricular fibrillation before, patient has syncope, patient has family history of sudden cardiac death, patient have septal wall thickness more than 30 millimeters of mercury, 30 millimeters. Then patient has unresponsive blood pressure changes on stress testing. patients with hypertrophic valve with these factors will benefit from ICD implantation. Cardiac pacing. So some patients have different degrees of heart blocks, 6-sinus syndrome, patients who have tachycardia bradycardia syndrome, patients who have atrial reticular block of varying degrees, 3rd degree heart block, 2nd degree heart block type 2. These patients would benefit from catheter pacing. Radiofrequency ablation is another procedure that can be done in the cardiac catheterization lab to help prevent sudden cardiac death. So you've got some people who have electrical problems in the heart, where structurally the heart is normal, but they have electrical ventricular accessory pathways that could lead them to developing ventricular arrhythmias. So these are patients that you need to identify the focus of the arrhythmia, the source of the arrhythmia, ablate it, and control the arrhythmias and prevent sudden cardiac death in this patient. Valvular heart diseases, patients who have aortic stenosis. In the cath lab, you could do this. The picture you're seeing there shows you there's an aortic valve that is thickened, that is not opening. So through the percutaneous means, you can actually introduce a catheter through that valve, put in a balloon, obstruction, and go. Cardiac surgery has a role in the prevention of sudden cardiac death, especially in people who have 3-vessel disease. Maybe when the catheterization surgeon talks about that, he will explain more on that. So in conclusion, sudden cardiac death continues to be a mental health challenge. Risk stratification of patients, primary and secondary prevention remains vital in death reduction from sudden cardiac death. So risk factor reduction, cardiac arrest intervention remains the cornerstone for the prevention of sudden cardiac death. Thank you.
So thank you very much, Dr. Kalu, for that very elucidative presentation. So this leads us to the next presenter in person of Dr. Premanand Ponov, who is the Chief Cardiothoracic and Vascular Surgeon at the Karen Hospital in Nairobi, Kenya, and has over 25 years experience and has performed more than 15,000 surgeries and over 150 open heart surgeries. And it's worthy of note here that Dr. Premanand performs coronary artery bypass graft surgeries on beating hearts. That is to say, the heart is not stopped when the surgery is going on, as against other similar operations where the heart is usually stopped and then a heart-lung machine takes over the function of the heart. He has a fellowship in heart and lung transplantation from the United States of America. And he has also served in reputable cardiothoracic centers in the US, Australia, and New Zealand, and has attended numerous international conferences, including numerous cardiac and other health topics. So permit me to welcome Dr. Premanand Ponov to give his presentation. And that will be the last presentation, after which we'll take the questions and the answers. So please remember to send in your questions via the chat box. Over to you, Dr. Premanand Ponov.
Thank you. Thank you very much. It's a pleasure talking to our friends in Cedarcrest, as well as from Nairobi Karen Hospital. Special regards to Felix and Umelo and all our friends. So today, both of my previous speakers have talked a lot about the medical aspects of sudden cardiac death, but I'll try to touch upon briefly and then go on to the mechanical and surgical options for sudden cardiac death. Yeah, okay. Now, as you know, it has been coined, or yeah. So any unexpected death, natural death, within 1 hour after the onset of symptoms is a sudden cardiac. So it is. So what it means is that after the onset of symptoms, if the patient dies in 1 hour due to unexpected natural cause, you can call it sudden cardiac death. As you know, there'll be absence of carotid pearls, altered sensorium, impaired respiration, all sort of things, And if you look at the hospital sudden cause of death, one is arrhythmia, which constitutes only 10%. 30% is due to refractory cardiac output state, and then of course infection and anoxic encephalopathy is the other causes for it. The risk factor, both of my colleagues who cardiology have told, is more like a coronary artery disease. Basically, it is found more in men than women. Smoking, lack of exercise, obesity, diabetes, family history, all these are risk factors. So I think if someone has got a strong risk factors, no harm in getting a wellness checkup, even though they are hale and hearty, so that we can prevent a sudden cardiac death in case if it happens. So signs and symptoms, as we all know, that when there is a sudden cardiac death, the pupil is dilated, no blood pressure, no respiratory movement, patient is unconscious. As you know, there is no pulse, and he is and death-like appearance. So that is what you find in a sudden cardiac death. So just to touch upon few of the data that we have. If you look on the right-hand side, it is 450,000 sudden cardiac deaths. Sorry, the previous one. 450,000 cases of cardiac death in a year. But remember, it is much more than if you combine everything like stroke and lung cancer, breast cancer, AIDS, everything put together. Still, this is a big number. So it's a cause of concern. If you do worldwide search in the industrial world, US, Western Europe, everywhere, the incidence is about 300,000 and survival is very less. Even if you are in the best place, the survival is very less. So I think it's very important that we give a real thought to it. So incidence, if you look at the main causes, as we have already discussed, ventricular tachycardia, low EF, previous myocardial infarction, coronary artery disease, I would say this is a major chunk of the cause for the sudden cardiac death. Of course, history of sudden cardiac death and other issues like cardiomyopathy, congestive heart failure, and things, long. The sudden cardiac death accounts for about 50% of the cardiac mortality. That's what I want to tell you. And another major point that you have to see is that whenever you do an autopsy, 90% of the victims are coronary artery disease. I think this is the main culprit of the sudden cardiac death, even though there are other reasons also. So just to summarize the causes, so you can divide it in multiple headings. One is called the ischemic heart disease, which causes myocardial infarction, weakness of the muscles, low ejection fraction. Then is the non-ischemic heart disease, whereby the heart is dilated, like cardiomyopathy, dilated cardiomyopathy, hypertrophic cardiomyopathy, valvular heart disease, and so on and so forth. And then comes structural, non-structural, what do you mean to say, the arrhythmias comes into this, like long QT syndrome, Rugadas syndrome, so on and so forth, heart block and all those. Then the non-cardiac causes. So basically cardiac and non-cardiac is the one which causes, mainly massive pulmonary embolism, hemorrhages in the, drowning and drug induced and all those. So this is the most of the causes that we enlight for a sudden cardiac death. So if you look at the signs of it, as you know, a successful CPR, suppose you confront with a sudden cardiac death, and if you do a successful CPR, these are the things which point towards that we are on the winning side. The patient will have spontaneous gasp or breathing will occur, normal heart rate will return, you find that pupil is reacting to light, the lungs will start to expand, and maybe the patient will start moving hands and legs, and the color will start to improve. I think if these are the sinister things that you have to look for, if your CPR is going to be if it is successful or not. So if these things come, that means you're on the winning side and you can go to the next level. So if you look at the treatable cause of cardiac, you can divide it into two. One is known as the H, another is known as the T. H means hypoxia, hypovolemia, low hydrogen ions, or call it acidosis, hyperkalemia, hypothermia. So these things can be corrected. So also if you look at the T part of it, toxins, cardiac tamponade, tension pneumothorax, thrombosis, pulmonary thrombosis, coronary thrombosis. So all these things. So the H and the T's that you see, all these causes for the sudden cardiac death can be corrected. Now, brief, touch down on the history. First artificial mouth-to-mouth ventilation was done about 500 BC before Christ. So it has got a long history. And you take down slowly, slowly. I think the most important thing that happened in 1980, where a cardiopulmonary resuscitation due to Peter Seffer, and the development of the cardiopulmonary bypass machine. So I think that is the most important thing in this. So if you can remember CAB, I know there are many viewers who are not doctors. C is for compression, A is for airway, and B is for breathing. I think these are the three main pillars of a successful resuscitation. When you compress, make sure that you really compress it so that you get the squeezing of the heart. Airway, tilt the patient's head back, lift the chin, and open the airway, as the diagram shows you. And breathing, give mouth to mouth if you don't have anything. Otherwise, you can use the gadgets, whatever we have. So then after you do the CAB, then you can go to the further thing like defibrillation, medication, hypothermia, which I'll talk to you about, extracorporeal membrane oxygenation, which is known as the ECMO. So let's talk about the hypothermic treatment for sudden cardiac death. This is mostly done, most of the papers have come from Australia and New Zealand. So I don't think do the. What the idea of this hypothermic treatment is to bring down the BMR, basic metabolic rate, thereby the consumption of oxygen can be reduced in the tissues so that the maintenance of the organs can be better. So this is the basis of the whole thing. So it has to be, the time initiation should be less than 4 to 6 hours of returning. So once the patient has been resuscitated, okay, and you think that patient is coming around, then I think then that's a time you can think of hypothermia, 4 to 6 hours. The idea is to reduce the core temperature to around 32 to 34. So it can be done in many ways. Most of the hospitals which have these cooling blankets, you can give intravenous cold saline, ice packs, cooling pads. So this is how you can cool the patient in whichever way you want so that the BMR comes down, oxygen consumption to the vessels come down, and you can maintain the patient. So the criteria, so let's exclusion criteria for hypothermic treatment. One is that if the patient is very elderly. Number two, if the patient has got some real malignant disease where you find his longevity is not good, or the patient had a recent major surgery or some head injuries, intracranial hemorrhage, and all these things, I don't think they qualify for a hypothermic treatment. So these patients, we should not actively go for a hypothermic treatment. But the major inclusion criteria could be if you resuscitate the patient, cardiac function returns spontaneously. If the young and if they are more than 18 years old and healthy, intubation is ventilated, intubated and ventilated. Glasgow's coma scale is 8 or less with purposeful movement. So all these things, if a patient has get into any of all these criteria, I think we can we can think of a hypothermic treatment. But this is where you should not really think about it. If hypothermic treatment, once again, long history. In 1950, Bigelow is the first man to do that, tried to do that. And of course, from 1997 onwards, a lot of people in Australia and New Zealand are trying to do this treatment. So next, let me talk about, that is hypothermic treatment. Next is the ECMO, extracorporeal membrane oxygenation for patients. This was first initiated in 1971. Look at this, the tubes and the wires which is running around the patient. This is the patient, and see, this is how they started off. But things have moved, the science and technology has progressed, and it has come to this stage, and now it is so small that you can take it in your hand. So mobile ECMO is one of the latest treatment that they do, especially in a well-established hospital, especially in Western world, and we are happy to say that Karen also has got an ECMO, and probably we are one of the hospitals, probably the hospital, which has got an ECMO in the East African area. So basically what is ECMO? I'll make it very simple. There are two types of ECMOs. One is called VV ECMO, that is veno-venous. Another is known as VA ECMO, veno-arterial ECMO. So basically what you do, take the blood from the patient. As you know, the patient is not doing well, heart is not beating, is not breathing. So take the blood from the patient, putting a cannula, as we have shown here, and take it to a roller palm, and then oxygenate, So then oxygenate the blood and then bring it back to the patient. is being artificially supported to maintain the life. So one of the things that I'm just wanted to show you this, when you put a cannula, the portion distal to the cannula, there can be ischemia. So many times in ECMO, you put a small tube to enhance the blood flow distally. That is what we do. So just a history, 1972, Dr. first man to do fully, and of course it has gone a lot of changes. And in 1975, Robert Bartlett is the first man to do pediatric ECMO. Look at the girl when she had the ECMO, and the girl celebrated 21 years. So it is a real, lifesaver in the modern world. So indications, so there are absolutely, let's talk about the contraindications first. So if you think that patient is not going to recover from the cardiac disease, or you say that the patient has gone into a stage of non-recoverable respiratory problem, I don't think we should not go for a ECMO. Or a chronic pulmonary hypertension, advanced malignancy, as I told you, obese patient. So if you think the patient is not going to come back in spite of the best effort, and has got a long-standing malignancy which is very severe, and he's going to die within 6 months, things like that, I think we should not go for ECMO. So, but you should go for an ECMO, especially if you think when you think that cardiac function can be reversed, the gas exchange can be corrected. So, and if you think that there's a good chance that this patient is going to come through, I think that's the patient we should institute the ECMO. So as I told you, there are two types of ECMO. One is known as VV ECMO, another is known as VA ECMO. VV ECMO, basically the difference is that I can make it very simple. VV ECMO is used to support the lung problem. For example, if the patient has got, especially when we are in the COVID era, most of these patients get VV ECMO. This is to support the lung, especially when the lung is failed, when it is fibrosis. So VV ECMO is basically done to support the lung. VA ECMO is done especially when you want to support the heart and the lung. So that's a basic difference between it. So basically in VV ECMO, you put one cannula into a main cannula into another vein, for example, the right iliac vein, and the left iliac vein, or the right iliac vein and the jugular vein. You can take the blood out, do the oxygenation, and with the help of a pump, you can push it back into the body. And this can be done, it can be supported, as we know from many reports, for a few months, patient can be supported, especially during the COVID era. ECMO is done, especially when the heart has failed. So we put, once again here, one cannula is into the major vein, the other cannula into the major artery. You can do it in the chest, or you can do it in the groin. So you take the blood from the patient, from the vein, onto the machine, oxygenate it, and push it back into the patient through the artery. So basically, it's like a cardiopulmonary bypass machine, but in a very smaller magnitude. So as I told you, VV ECMO and VA ECMO. VV ECMO, if you look on the right-hand side, it is basically used for ARDS, smoke inhalation, COVID, aspiration pneumonia, any of all these lung, when the lung is not working, whatever may be the reason, maybe it is because of trauma, it may be due to contusion or post-op, whatever it is, VV ECMO is done. But in a VA ECMO, basically you can do as a support to, suppose you do a major heart surgery, you think that the patient is not coming off the cardiopulmonary bypass machine, whatever may be the reason, you can put the patient on ECMO, VA ECMO, and take the patient back to ICU. Or a massive myocardial infarction whereby the heart has failed, whatever may be the reason. Myocardial infarction causing free wall rupture, or arrhythmia, which is not amenable to treatment, or DC shock. All these patients, or post-sepsis cardiac shock, viral myocarditis, massive, so all sort of things where you find the heart is not doing a good job, you think that patient is going to go down. I think VA ECMO is a good thing so that you can support it. So VA ECMO is for cardiac support, VV ECMO is for the lung support. So remember always, there are some, it's not the holy grail, it has got its own problem. The practical difficulty is that one is cost. As you know, I can tell you approximately in Kenya, the consumable itself is about 600 to 700,000 shillings for this ECMO, plus the rest of the expenses added. So it is a cost. Cost is a major factor. Then it is very labor intensive. You need trained staff to look after the patient, and you also need a good blood bank support 24/7. Now, to manage an ECMO, as you know, we are putting tubes into the main vessel, so the patient has to be anticoagulated. You may have to give platelet and other transfusion things. Chance of sepsis is there because there are tubes. Nutrition to the patient, because if the patient is going to be on ECMO for a long time, you have to look after the parenteral nutrition part. One of the main key part of all these ECMO is to prevent LV distension. If the LV get distended, I think the game is lost. So I think you have to prevent the LV distension at any cost. Then you have to monitor the patient. So a lot of things have to go all along with this. But remember, it has got its own problem. Because you give anticoagulation, there can be chance of bleeding, there can be thrombocytopenia, there can be infection because you put tubes inside the major blood vessel, there can be intracerebral hemorrhage because of the anticoagulant, so on and so forth. So remember, it is a very specialized treatment. It has got its own problem, but it has got its own benefit. So you need a specialized team to look after it with a 24/7 blood bank support. Then I think it is a good thing. And as you know that nowadays, people in a Western world, they started doing it percutaneously. And a good ECMO machine is a part of the good emergency system whereby any patient can be supported. It's just a picture on the right in the vein. So through the vein, you take out the blood, oxygenate it, bring it back through the artery. So, and on the right hand, on the left hand side, you see the arrow. That is the one which I was talking, the small cannula which goes distal to the cannulation so that it perfuses the leg. Because leg ischemia is a very common problem, especially if you are planning to do a long-term echo. So these are the just to brief you. So don't get scared. This is how a patient, a sick patient, being transported by aircraft. I think it's a picture from New Zealand, I think. So the monitoring facilities, ECMOs, and all sort of things. Patient is somewhere in the middle. If you look very carefully, I don't know where it is, but it is somewhere in the middle. So this is how they do it. But it is very labor intensive. A lot of trained staff you need, and they have to work in tandem. So I just want to tell you that things are moving. A lot of research and development has happened. The catheter has changed. Percutaneous ECMO is one of the things that they do nowadays in the A&E when the patient come in a sick state. And as you know, Lucas 2 chest compression system, previously when the patient when you do the resuscitation to the patient, we jump on the chest. But once you put the Lucas 2, your hands are free. It will compress the heart and you can use your hand for much better things. So these are some of the advances that is going on in the world. I want to tell you a few words regarding as you know, coronary artery disease and its sequelae constitute about 90% of the sudden cardiac death. I just want to tell you some of the, as you know, my colleagues have told about angioplasty and stenting. I will talk briefly about surgery part of it. Now, as you know, when you do a bypass surgery, usually you stop the heart. But you can also do, when you stop the heart, it has got its own problem. For example, it triggers systemic, and it becomes complex, the cost goes up. So but the traditional teaching has been to stop the heart and do it because they feel, the old school feels that you can do a good work when the heart is stopped. So protection can be better. But I think things have changed and surgeons have become more trained and better. They feel that we can do equally good procedure with a beating heart. So by this, the anesthesia time comes down, less blood consumption, the cost comes down, patient go home at a much early date, and the inflammatory response is also less. This is just a brief picturization of what we do in beating heart. So this is the chest has been opened with a retractor, and this is known as the octopus, and this is called the starfish. This is the heart. This is used to position the heart whichever way you want, so that you can do a bypass surgery here. So when you put this here, the heart will be beating, but this area remains more or less stable, and you do whatever has to be done. So these are some of the things which I'll show you a small clipping by which you apply this, do the surgery just like a general surgery, and patient goes on. So just to say, this is our distribution of case distribution in a Karen hospital. As you know, most of the big chunk is valve surgery, single valve, double valve, 3 valves. And of course, ASD, VSD, PDA, the pediatric cases constitute the rest. Then CABG has been more and more we are seeing, and we are doing more and more CABG nowadays, which was unheard of maybe in the last 10 years. And of course, aneurysm repair, different, not only stenting, but also surgical repairs like Bental we do. Just want to show you, this is the coronary angiogram picture where show there is a narrowing there. So this is how it starts. And if you don't take care of it, this is how it becomes. And then think of this true lumen, it's becoming narrow and narrow, and ultimately when it's completely closed up, and the patient gets a big myocardial infarction. So just wanted to show you these are the type of cases we do. Forget about these are old numbers. So DVR, MVR, AVR, CABG, ASD, PTA, all sort of things. We do everything in the chest, thoracic and vascular and cardiac, except for children, very small children. Just wanted to show you a small clipping how we do the beating heart. I hope it will keep you awake by seeing this. So this is a surgery which we do very often here. So the heart is beating. This is the octopus I was talking to you about, this instrument that has been fixed onto the anterior surface of the heart. Here is the LAD, which is the left anterior descending, the main artery which supplies the left ventricle, which is the pumping chamber. So I have taken the internal mammary artery or internal thoracic artery from inside the left side of the chest, and it is being anastomosed onto the LAD. So we use usually 7-0 or 6-0 proline for the anastomosis. As you know, always the proline has to be dry and break it. And this is called a blower mixture. That there are two tubes here. Through one, sometimes oxygen comes through, and through the other tube, the saline comes. So you can adjust it. So it comes like a mist at the end of it, so that you can see it. So this, I just wanted to show you a small clipping. So nothing keep you more happy than a patient who sits up. This is a patient which I did previous day in the afternoon, next day morning when you come for a round, here is a patient sitting up, having her breakfast. So nothing more gratifying and happy than seeing a patient who's sitting up and smiling at you. So this is why I do CABG on a beating heart. As you know, the less blood products, less ICU stay, less inotropic support, less inflammatory reaction, and cost also comes down to about 30 to 40%. I hope it was clear.
So thank you very much, Dr. Premanand, for that lovely presentation. For those who are just joining us, I would just like to give a reminder of what we're talking about this moment. We have been talking about the prevention of sudden cardiac death. And they were specifying, or particularly we are talking about using of cardiac catheterization interventions in the prevention of sudden cardiac death. So we'll move to the questions and answers session. I want to thank the presenters once again. So we are going to take the questions in threes as possible, and we're going to, as much as possible, direct it to each of the presenters. But I would like to say at this point that even though we are directing the questions to a particular presenter, the other presenters can also throw more light or insight to some of the questions, in terms of answering them. So I'm going to read the questions and then they'll be answered by the presenter. But before I do that, there's a particular question I think is directed to me. And it says, are there any plan to reach a wider audience via a different platform with this important message? So yes, presently plans are being made to reach a wider audience through the Brekete TV and various other social medias like Sound City Radio. And then on Channels TV, there's going to be during the 8 p.m. on Friday, the 26th of November. And then on the 29th, which is a Saturday, 27th, by 9 a.m., there will be a live discussion about the issue, this particular issue, at the channel's television. sorry if this is too technical for the layman. You can send your questions to the doctors now, or even to the number on the flyer that is being displayed. I'm going to display that presently, so please, you can send your number to that. So back to, we'll get that later. I'll send the numbers and I'll put up the flyer later. So let's quickly go to the question and answer session. I'll start with Dr. Kalu, please. I'll take 2 or 3 questions at a go and see how far we can go with the questions. So for Dr. Kalu first, your first question says, can more insights be thrown on the risk of DM as a factor to sudden cardiac death? More insights on diabetes mellitus as a risk factor to sudden cardiac death. Then the second one says that could incessant numbness in the legs and hands be associated with sudden cardiac symptoms, and what can be done? I hope you got the questions, Dr. Kalu.
Yeah, we know is a metabolic disease that affects, that's associated with hyperglycemia, that's elevated blood glucose level. And we know that this blood glucose level that is elevated gets deposited in the blood vessels. Diabetes also is associated with metabolic disorders of lipids, that's cholesterol levels. All these abnormalities get attached in the blood vessels. Okay, and if it's not controlled with time, it could lead to narrowing of blood vessels. And what do you have with you? It leads to coronary artery disease. What do you mean by coronary artery disease? Simply narrowing of blood vessels supplying the heart. So diabetes is a major risk factor for sudden cardiac death, in the sense that it's one of the risk factors that leads to coronary artery disease, narrowing of blood vessels supplying the heart. So diabetes is a big issue. Initially, diabetes was referred as an endocrine disease. Current thinking, we think diabetes is more of a cardiovascular disease, not necessarily an endocrine disease, because it ends up in the blood vessels and leads to coronary artery disease, and that presents patient to sudden cardiac death. So diabetes is a big issue, and that it should be really addressed and treated aggressively. The second question you talked about, I didn't get it again. Can you please take it again? Sorry. Dr. Johnny, can you tell the second question again?
Yes. The second question says, could incessant numbness in the legs and hands be associated with sudden cardiac death symptoms? And
asking this question probably has diabetics. So there are a lot of causes, there are a lot of things that can cause numbness of the hands and legs, but diabetes is a major cause. So if the cause of numbness of the hands and the legs, remember I said before that diabetes is a cardiovascular disease. And when we talk about cardiovascular, we talk about cardio means the heart, vascular means the blood vessels. So if the blood vessels supplying the lower limbs and the hands, if they are narrowed, you're going to have numbness of the hands or the feet. Yes, so there's some associations there. So I would think so. If it's from diabetes, then definitely. Or if it's from hypertension, definitely you are at risk of developing sudden cardiac death, and that should be evaluated. Thank you.
thank you a lot, Dr. Kalu. Maybe we should just take 2 more questions with you before I go to Dr. Anthony. The next question says, how often should screening be done for early detection for those at risk of sudden cardiac death? How often should screening be done for early detection for those at risk of sudden cardiac death? Then finally, that chest pain that radiates to the back, around the upper breast and axilla on the left, sometimes to the right, what could it indicate? Chest pain radiating to the back, around the upper breast and axilla on the left, and sometimes to the right. What could it indicate? So I think we can take that before I move to the questions for Dr. Anthony.
Okay, screening. So when you talk about screening for the general population, there are guidelines. So it depends on the population you're looking at. Okay. If you're looking at population, people who have hypertrophy, there are specific guidelines on how you want to screen them. If you're looking at young adults who are going to participate in athletes, there are specific screening guidelines for them. Okay. If you're looking at general population, there are specific screening guidelines for them. So this is actually a wide question, and but the idea is to risk stratify your patient. You want to look at, is this person diabetic? What is the age of this patient? Is the person hypertensive? Has this person had a previous cardiovascular event? Okay, is there any family history of sudden cardiac death and all that? So it's a whole lot you're looking at there. So looking at the question on chest pain symptom, chest pain could be from as a result of many things. Okay, but the chest pain that is usually cardiovascular, chest pain that comes in its action, okay, it could be a heaviness, a gripping, it radiates to the left arm, jaw, okay, it could go to the back. But the idea is that if you have chest pain, you need to be evaluated, because sometimes the symptoms they are not really that sensitive and specific. Okay, so if you've got chest pain, you need to evaluate that. Sometimes people will need to have chest pain, and yet they have serious on the background cardiovascular disease. Thank you.
Thank you very much for that, Dr. Kalu. The next set of questions goes to Dr. Anthony Gikonyo. The first question here says, how can one differentiate between chest pain that may be by ulcer or that can cause? How can one differentiate between chest pain that may be as a result of ulcer or one that can cause heart attack? Then the second one, do we have any evidence on the cause of sudden cardiac death in Africa, as most studies are from USA and Europe? Do we have any evidence on the cause of sudden cardiac death in Africa, as most studies are from USA and Europe? I think one of the presenters gave a slide that showed studies from Africa. So I'll allow Dr. Anthony to answer, please.
Thank you for that question. It's extremely difficult just from listening to somebody's story to decide whether the pain is from an ulcer or from the heart, and that's because a lot of the symptoms overlap. So the patient may have chest pain or chest discomfort. If we're thinking it's from the heart, it would usually be on the left side, radiating to the left hand. It would be associated with difficulty breathing, maybe sweating. It's worse on exertion and resolves with rest. Whereas if it's from an ulcer, it's usually related to either eating or being hungry. The pain is central, radiating up to the throat. It's associated with a bad taste in the mouth. And then it usually is triggered by certain foods. But whenever you see a doctor, one of the things that they will do is create a differential diagnosis, where we say number one is what we think the most likely diagnosis is, but we still have number 2, 3, and 4 or more that says if our first idea is not correct, then we have other things to try and determine what's causing the symptoms. And so you'll find that if somebody comes with chest discomfort, even though we think that it's from an ulcer, we'll still ask for an ECG to be performed just to make sure that we don't miss out on a cardiac disease. Also, we will do some blood tests, which include a blood sugar, cholesterol level, and in specific instances, looking for damage to the heart, and that would be a test called a troponin. We will also ask, if possible, to do an echo and a stress test. And if these are all negative, then we'll go down the route of looking for ulcers. And that would then mean referral to a specialist a GI specialist, and then possible endoscopy. But it's usually a challenge to discern one from the other, just based on the history. The doctor and the patient will require to do some tests and then determine which of those two is there. But we would want to exclude the life-threatening cause, which is heart disease, rather than giving a diagnosis of an ulcer when somebody's actually having a heart attack. Thank you.
Thank you very much, Dr. Anthony. And I'll go to the other questions here are pacing during coronary catheterization. Should it be prophylactic or therapeutic? Pacing during coronary catheterization, should it be prophylactic or therapeutic? Then the second one, what sort of annual tests or checks should be done to keep up with the condition of the heart? What sort of annual tests or checks should be done to keep up with the condition of the heart? And finally, are there evidences about the role of antiplatelets in the prevention of sudden cardiac death? Are there evidences or evidence about the role of antiplatelets in the prevention of sudden cardiac death? I think we can take those set of questions now.
Thank you. I think for any, as you know, the right coronary artery is the one which supplies the AV node. So I think it is always the right coronary artery block which causes the conduction problem. As you saw from my colleague Anthony Kikonio, when he showed the clipping of the angiogram, when he was doing an angioplasty for the right coronary artery or the right RCA, he was putting a temporary pacing wire. So I think it is the right which is mostly the culprit. And if you have any element of doubt that it can cause problem, there is no harm in putting a temporary pacing wire as a safety measure. Or if the patient's heart rate is low, it is better to have a temporary pacing wire as a standby. It is not routinely used for every case for angiogram or angioplasty to have a pacing wire, but I think it is available in all the good places in the theater, I mean in the cath lab. So anytime 30 seconds. Now, number 2 question, tell me again, which is the next one?
Number 2 question is talking about what sort of annual checks or tests should be done to keep up with the condition of the heart.
Yeah, so we recommend, most of the good hospitals recommend what is known as a wellness clinic, whereby we say that all the subjects in material, the fact that whether you have risk factors or not, anyone more than 45 and 50 should have an annual check. That's what we recommend for all the patients, especially more so if there's a strong family history of heart problem. So especially more so if the patient has got diabetes, hypertension, stress, eating all sort of junk food, overweight, lack of exercise, all these risk factors. I think it is mandatory that these people should have a regular checkup. Now, regarding the checkup, what we do is to start off with a general physical examination, ECG, an echo, and of course the blood checkup, the cholesterol, the lipid profile, urea creatinine, and so on and so forth. And if you have any element, if suppose this patient has got some ECG changes, If the echo shows that the myocardium is not contracting well, if we have the element of doubt that he has got some coronary artery disease, especially more so if he has got a family history, we always tell them to get further checkup so that we can prevent a sudden cardiac death. So that if you do an angiogram, or sometimes as a screening procedure, we do what is known as CT coronary angiogram, which I believe is inferior to the traditional coronary angiogram. We can pick up the disease very early in the stage and can do whatever is needed. Maybe it is stenting, maybe it is surgery. So I think one of the ways to prevent the sudden cardiac death is to keep your eyes open, encourage the people who are at high risk to get checked up. Terms goes, it is better to nip in the bud, which is the third one. Third question. No. Oh, you were talking about antiplatelet, is it?
Okay, the third question.
Yes.
Yeah, it says, are there evidence about the role of antiplatelets in the prevention of sudden cardiac death? Any evidence on the use of antiplatelets?
It has been a tradition throughout the world, not only in Africa, anywhere in the world. Previously it used to say that apple a day keeps the doctor away. Now aspirin a day keeps the doctor away. I think that's what the saying says. But remember that just by giving aspirin or antiplatelet, just like that, has its own problem. It can cause gastric bleed, sometimes cerebral bleed, and all sort of things. But I think if a patient, so you have to weigh the risk and benefits of antiplatelet before you prescribe them. But if you think the patient has got the risk factors, there is a history and he smokes, drinks, and do all sort of things, I think we have to start it. So I think there is enough evidence throughout the world to say that antiplatelet does have a role to play. Only thing, we have to play it cautiously.
Okay, so thank you very much, Dr. Anthony and colleague, for the answers to those questions. I think I'll move on to the next set of questions, and therefore Dr. Premanand Ponoth. The first set of questions for Dr. Premanand says, you spoke about data indicating the risk of sudden cardiac death to be 3 times more in men. Are there specific interventions to minimize this risk? Dr. Premanand. Cardiac deaths being 3 times more in men, are there specific minimize this? Then secondly, can positioning increase the risk of intraoperative sudden cardiac death? Can positioning increase the risk of intraoperative sudden cardiac death? Thank you very much.
What do you mean by positioning means? What exactly? Can you just tell me what exactly by positioning means? Hello, I didn't get it. So I would say the first question, I will answer it. As you know, 90% of the sudden cardiac death, the cause has been found to be coronary artery disease. It has been proved beyond.
Sorry, to clarify. What do you mean by changing positions during operation, during surgery?
Oh, during surgery. Okay.
Yes.
I'll answer.
Can it increase the risk of sudden cardiac death?
Okay, so let me answer the first one. It has been, as you know, 90% of the sudden cardiac death, the cause has been studied and evaluated and found that coronary artery disease is a main culprit for it. So it has been studied and found that it is men who have more coronary artery disease than women. As you know, there are certain disease profiles. Some diseases are more in men, some diseases are more in female. So if a person is found to be at risk of having this problem, it is better to have a checkup, what is known as a wellness checkup, or a checkup before he gets the symptoms, so that we can find out the test I told you previously, a good physical examination, including an ECG, start with an ECG, maybe a treadmill test, echocardiogram, and if needed, an angiogram. So I think that's the way you climb up the ladder. So it is more found in men. So these are the tests, plus the blood evaluation, lipid profile, urea-creatinine, sugar, so on and so forth. I think that's the way we have to climb up the ladder. So coronary artery prevalent in men, Africa and Asia, but throughout the world, it's a known fact. Of course, women also do get it, but it's more prevalent in men. So I think these are the tests by which we have to evaluate the patient. And number two, changing of position during the surgery, I don't think it does cause any, it doesn't matter much, because we do change positions in the theater, and I don't think it will trigger a sudden cardiac death. Some of the things I can tell you, extend that question. When you are dealing with, when you are going to do a bypass surgery for a left main disease, which is called one of the major, it is also known as a widow maker, in a layman's term. When we do a surgery for this type of left main disease, sometimes during the time of induction, if the anesthetist is not very experienced, can induce a sudden ventricular tachycardia leading to fibrillation and death. So these type of patients, it has to be cautious when we do the surgery at the time of anesthesia. Everyone will be on the toes, the nurses will be all dressed up, so also the junior surgeon, and the defibrillator will be at standby, so that in case if it goes into any problem, we are ready to shock the patient, open the chest, and go on to pump, on to bypass. Thank you.
Thank you very much, Dr. Premanan. One last question. It says, how do we prevent left ventricular dilatation of the heart during ECMO? How do we prevent left ventricular dilatation of the heart during ECMO?
Yeah, so by which we run the ECMO or any pump for the bypass machine is to prevent the left ventricle, which is the main pumping chamber, from dilatation. As you know, when the heart dilates, basically what happens, the myofibrils breaks when the myocardium. So this is what the surgeon we always try to prevent. We don't want any chamber, especially the left ventricle, to dilate to such an extent that it undergoes damage. So when, as I told you, in ECMO, it is basically a miniature cardiopulmonary bypass machine. So there is a guy who looks after it on a 24/7 basis. His name is they are called the perfusionist. So by doing a proper run as well as doing an ECMO will give us a good idea whether the LV is getting dilated or not. If the LV is dilated, we have to alter the perfusion run accordingly, so that the LV is emptied and LV dilatation is avoided. It is a perfusionist who does it. Thank you.
So thank you very much, Dr. Premanand. And I think we've virtually answered all the questions that are available. And I want to, at this point in time, take time to thank everyone for attending. Sorry.
Esther, all these clothes, are they not dirty? Dirty clothes that you hang on your bed, are they not dirty clothes? Huh? Are you taking the...
So, seems there is one more question just popping up now. We'll try to get the question and then get it answered. Sorry, I'm trying to get the chat. Okay. So, like I said, there is one more question. Okay. Someone asks how we can get the CME. I'm going to address that, before the end of the whole session. I'm going to address that. Then the other question is, what is radio frequency ablation? What is radio frequency? That's the last question for today. What is radio frequency?
So radio frequency ablation is a technique that's used to interrupt the conductive pathway in the heart to stop arrhythmias. It can be used to treat atrial fibrillation, atrial tachycardia, supraventricular tachycardias, and even ventricular tachycardia. It's a procedure performed in the cath lab. The access is usually through the right femoral artery, right femoral vein. There will be catheters or leads placed in the right atrium and in the coronary sinus and in the right ventricle. Electrical tracings will be made to determine where the abnormal pathway is. And once it's identified, then the radio frequency, which is a type of energy, is applied directly to the heart, or which causes a form in a very small part of the heart that then interrupts these abnormal pathways and prevents the abnormal heart rhythm from recurring.
It's okay. Thank you very much, Dr. Anthony, for the answer to that last question. At this point, I would like to thank everyone for attending and taking out time to be here. And I pretty much believe that it has been quite beneficial to everyone. I want to say special thanks to the speakers, the presenters, for the wonderful presentations, and to tell us, everyone, that these speakers will be available for consultation during the cardiac camp. They will be available for consultation during the cardiac camp. Also, for inquiries and registration, cardiologists are also invited to come and to refer patients for procedures. So for inquiries and consultation, let's take down this number, 090-880-40-880. I take it again, 090-880-40-880. So whatever inquiries you have, and then for registrations, please, you can contact that number. And please, it's worthy of note, or it suffice to say that cardiac camp, there will be free consultations, and then there will also be discounts on investigations and procedures. So let's take note of that. There will be discounts on investigations and procedures, while there'll be free consultations. So let's invite our friends and families to the cardiac camp, which begins, like I said, on the 29th of November to the 1st of December at the Cedarcrest Hospitals, Gudu, Abuja in Nigeria. Also, as regards the video of the entire presentation, it will be uploaded to the Cedarcrest YouTube channel, and the link has already been posted on the chat box. Let's check the chat box. The link has been posted there, so we can link up with the presentation on the YouTube, Cedarcrest YouTube channel. Then as regards the CME forms, like I also earlier said, that for those who were registered and attended this program, we're going to scan the CME forms and points to them within 7 working days via their email addresses that they have provided. So within 7 working days, we'll forward the CME points form to their various emails. If you have not done that, please, I think, well, it's already late for you to be able to register. So, but please, let's take note of that. Then, if within 7 days or after 7 days, you have not received your CME forms, then you can contact this number. Please contact this number if after 7 days you have not gotten the CME. Then contact this number, 090-875-08335. I take it again, 090-875-08335. 08335. So I'll still put up the flyer as we continue. At this point, I would like to close the meeting. Once again, I want to thank everyone for coming on this presentation and for finding out time to attend this webinar session. Till we meet again next time, God bless you and see you at the cardiac camp beginning on November 29th to the 1st of December. God bless you. Invite family and friends.